Room in front of us. Happy you made it all through the rain. My name is Sebastian Weiss. I'm an infectious disease specialist. I have no clue how I get to chair this session. Massive bleeding is something rather far from what I usually do. So I'm very glad if you ask questions in between so that I don't make a fool myself here in the morning. We'll start with Steffen Witzner from Rostock University on extracorporeal anticoagulant removal in emergency surgeries. Stage is yours.
Good morning, ladies and gentlemen, Mr. Chairman. Yeah, this is about the idea to remove anticoagulants with a sorbent in cases where it has to be fast. And this is lovely Rostock, where I come from. Come and see us, old Hanseatic town at the shores of Baltic Sea. My disclosures, it's a relevant one because I'm talking about a device from cytosorbents. And we were among the early users clinically, and we did lab work in the field of drug removal. Extracorporeal therapies. Just as a reminder, we try to remove harmful substances. Typically, we talk about bacteria, viruses, beyond dialysis, and sometimes cells. But obviously, there's always the danger that you do harm to your patient by removing drugs. The other way, you could look at it as an option to remove drugs, and this is where I'll come in the second part of the lecture. So I shortly review the knowledge we have with regard to removal of drugs. Typically, the device is used in cytokine storm situations like septic shock, or sometimes in the perioperative setting as well. But there's always safety concerns with new extracorporeal therapies. There was work done in this field, and yes, there is relevant removal of drugs. If you use it, this is in septic shock patients, and what you see here, what these colleagues did is follow 7 of their patients with the vancomycin levels in red without the device, and what we see is what we always see, that typically, if we measure, then we see normal or low levels. If they added for septic shock this adsorber device in the extracorporeal circuit, you see in blue that they all were too low. So the device is eating vancomycin. So these colleagues. And you can, if you're interested in, typically accessible to extracorporeal removal are drugs that have either a high free fraction in plasma and or a low volume of distribution. It's everything below 2 liters per kilo body weight, and vancomycin clearly belongs in both fractions. So it's removable by dialysis and adsorption. So what they did is they followed these levels. This is without the sorbent. This is when they implemented the sorbent, and you see that on average the level went down, and the reaction was that they said then, we have a new standard, or define one, to give an extra bolus of 500 milligram vancomycin over 2 hours if we have a sorbent in, and then we are fine with that, and the levels are stable. So this is how the knowledge, so to say, in intensive care with use of these extracorporeal devices is developing. Same as for meropenem, as you can see here, single case. There in every day there was for a couple of hours this device was applied, and the meropenem was 3 grams per day. And what they saw when they followed the levels is that, yes, it goes down. It was not dramatically, but it went down. So there's adsorption to the, some at least, to the sorbent. And again, there's a low volume of distribution. And they said, whenever possible, use these devices, do drug monitoring if you can. Or more feasible probably is to start right away with higher loading doses or shorter intervals if you give your drugs. And there was, a lot of in vitro work was done to see how clearance is with, you cannot see it, but believe me, different drugs, antibiotics, anti-infectives were tested. What I want to show you is that uniformly all these experiments show that adsorption, what makes sense, takes place within the first like 15, 30 minutes, so that's the more dangerous part if you use it and you have a fresh adsorbent in your patient in continuous use, then don't give your drug boluses the same moment or increase the dosage. That's the message, I think. More work was done on the PIC. Colleagues from Switzerland, Antoine Schneider's group, did a lot of work trying in anti-infectives, and they grouped them, and you can all read this in moderate, mild, and unwesentlich, so neglectable, something like that. Sorry, in German. Next. A good summary of the drug removal was published last year, and these colleagues reviewed literature about 50 drugs, with different uses, anti-infectives being among them, and again grouped them in low, moderate, high removal, and then came up with these tables saying, yeah, there are some where there's no removal actually, and then there's significant removal, and I just show you that this data is there. Vancomycin is here again. Here you see already one of these substances, apixaban, that we'll talk about in a second. And then it's good to remind us using these devices that typically these direct hemoadsorption devices like Cytosorb are used in combination with CVVH. You can use it standalone, but typically we at least do this in combination, and CVVH in itself has a removal capacity for drugs, as we know. Often don't think of it, and obviously the combination when both actually have a high removal capacity is where it really, gets interesting. Again, vancomycin in here. And we need to, or should know that, and react with probably higher dosages of these drugs. Now I come to what I was invited for. It's drug overdose and poisoning. So this downside of a new device has a bright side as well, so we can use it in cases of drug overdose and poisoning. I omit for time reasons poisoning, but there was quite a lot of work done there as well, and we come to drug overdose. This was work from our group. Andreas Körtke tested rivaroxaban and whether the adsorbent would eat rivaroxaban. That was the case. So this is a lab experiment done, an easy one, and you see again within the first 30 minutes from a meaningful starting concentration, he could lower the concentration to to much lower concentrations. You know, said, well, maybe this is interesting for clinical use later, and this work like that was done for actually all the new oral anticoagulants. We have that for dabigatran, edoxaban, apixaban, and ticagrelor. So in vitro, if you have a blood sample, you can remove these drugs using this sorbent. And the first I know of that made clinical use of that is this group from Hamburg, I guess, and they put a sorbent into the cardiopulmonary bypass in situations where they had to do emergency surgery in patients with high risk of bleeding, meaning they were on either rivaroxaban or ticagrelor, in this case 12 and 43 patients, and they put them either on the sorbent or not. And this is what happened. The drainage volume went down remarkably if the sorbent was in the circuit, as you can see here for both rivaroxaban, ticagrelor, and they had this as a readout for less bleeding, what was good. And it made more analysis with regard to transfusions or need for red blood cells. This was definitely in favor of the adsorption group with less blood cells needed to be transfused, and the same is true for platelets, and for the, in the end, re-thoracotomy rate, that was 0 here and was not 0 in the standard group in these high-risk bleeders. So that was good. The same group has then redone this work in a clinically different setting. This is acute type A aortic dissections, and basically, to cut that short, came to the same conclusion with the drainage volume being lower and significantly lower in the adsorption group. Yeah, and more work was done then, case reports amounted, basically they all came to this, to the same conclusion, and in vitro work was done, again, to show that all these 4 new anticoagulants, including the ticagrelor, could be removed. Go over this, and resulted actually in some acknowledge just recently the new guideline recommendation for emergency cardiac surgery has a section that is asking how should intraoperative and postoperative bleeding be stopped and anemia be managed, and says can be used in patients on ticagrelor, rivaroxaban undergoing emergency cardiac surgery. Hemoadsorption may be considered as an adjuvant therapy to reduce bleeding complications. This is where we stand, and this is what I wanted to show you today. Brings me to my conclusion, Mr. Chairman, that the sorbent is there. There's other hemoadsorption devices, especially against endotoxinemia. We're waiting data from United States. The Cytosorb is in clinical use, and especially in Europe and other countries. And we have a lot of reports saying that basically, yes, you can do that. It appears clinically safe in ill patients. And drug removal is clinically relevant for certain drugs, especially those with a low volume of distribution, high free fractions. What we need to consider in all these settings where we, for instance, treat septic patients, what we can do there is use high loading doses, and do drug monitoring. And then definitely it's an interesting therapeutic option in intoxications, drug overdoses, and we may add as a new potential or indication emergency cardiac surgery settings in high-risk bleeders on these oral anticoagulants. And there's more clinical studies ongoing in this field. Thank you very much.
Thank you for this opening talk. I indeed have one question to start with. This is a very unspecific device. So you would use the same device for pretty much everything, if I understand it right.
Yeah. Mm-hmm.
Other developments to make it more specific, that you would have one Cytosorb for that specifically or more concentrated fishes out anticoagulants versus one more for toxins, or will that not be possible?
I'm not aware of a specific anticoagulant removal device. Mm-hmm. I know that in the sepsis field, the company has a research program that's heading towards endotoxins and maybe other toxins that they don't take with this device. But actually, as it appears, it's pretty effective as it is for the removal of these, the mentioned anticoagulants.
Excellent.
Well, yeah, Alexander Vlaar. Thanks for the presentation. Only one thing about the slides where you have the removal versus non in emergency cardiac surgery. Although the median probably is lower in thorax drainage, still there are a few of them quite high, even the same or even higher compared to the controls regarding drainage production. Did you look, or did the group there look at the levels of the anticoagulants? So it didn't work, or was there a surgical bleeding?
That's an excellent question, and I have no good answer, so I don't know this. They did not follow the anti-factor 10 or whatever specific levels, for the anticoagulants. That was done in vitro experiments, I know, but not in this clinical report. A good question, and both is possible, you know, more treatment needed, but they all wanted to be fast, so they just put one of these sorbents just into the bypass, you know, so that was the standard.
Beverly Hunt from London, thank you very much. You're removing a percentage of the anticoagulant here, or are you totally removing the anticoagulant? I wasn't clear from the figures, because if you do hemodialysis for dabigatran, you'll remove about 60% anyway. So what is the percentage removal is what I'm asking. Thank you.
That's higher than 60%. That's higher than 90% removal, actually.
There's one more question.
Can you say anything about use outside cardiac surgery? Let's say a head injured patient on rivaroxaban. Should we use it or?
No, I'm not aware of data in that field. It might make sense if the question is that you have someone with a high reading risk, and it doesn't have to be cardiac surgery, obviously, you know, so you come to brain damage comes to mind and other interventions, but I'm not aware of clinical reports so far.
All right, thanks a lot for the opening talk. Next one is Alexander Vla from Amsterdam University, who's going to tell us about platelet transfusions.
Yes, so thank you very much for the introduction and also the invitation to present for the first time the results of the PACER study, a randomized controlled trial to investigate whether prophylactic platelet transfusions prior an intervention, CVC placement in severe thrombocytopenic patient is useful. It was an 8-year journey to get results. So no conflicts of interest for this presentation. So the question is, in severe thrombocytopenia, when we are talking below 10 or 20, 30, 40, 50, what should we do? So I think here in practice, probably there are different approaches. Some of them just do an intervention, others first transfuse. It's probably also between specialty difference. When you're maybe in the ICU, you're a bit more restrictive, definitely due to all the trials which have been published in the past decades showing that a restrictive transfusion policy is safe. Well, maybe in another area in medicine, you might be a bit more liberal. So, and this is also, I think, reflected by all the guidelines worldwide in this setting. What should you do prior a CVC placement? It can be a CVC catheter for dialysis or for vasopressors. It can be tunnels. And actually, in the ISICEM guideline, it was stated we cannot recommend any threshold between 10 and 50 because there is no literature. You see in other guidelines, it's already going down because we had, of course, all the red blood cell transfusions. It's safe. The patch and the Matisse trial showing that in specific settings, actually platelet transfusion is causing harm. So I think in that way, people were already starting to change the guidelines, and the old was 50, and people were saying already consider platelet transfusion only when it's below 20, when you're using, for example, ultrasound techniques. And I think this is also a very important point to take, that the practice has changed. We have been moving from landmark techniques into ultrasound technique for CVC placement. And what you see here is that the complication rate really went down, the success rate went up, and the arterial puncture rate went down, hematoma went down, and other complications went down as well. So you can imagine that if you use ultrasound, and the other thing is, of course, experience. We know from literature, when you've done more than 50 CVC placements, your, well, improvement is stabilizing, and in that way, maybe it's safe to abandon any prophylactic platelet transfusion in severe thrombocytopenic patients. The other thing is, of course, to think about is the transfusion reactions, because platelets, they are ranking high on all kind of transfusion reactions, such as allergic reaction, febrile reactions, hypertension, dyspnea, but I think definitely for the ICU, TACO, TRALI, infection rates are very important ones, and well, still, this is the passive reporting per 100,000 transfusion. We've done quite some research on TRALI, TACO in the ICU, and in the prospective studies, they even end up into 1 in 10 or 15 patients being transfused, so probably it's a bit higher. But so there is also a downside of transfusion. Thanks. The other thing is, of course, is the shortage of blood products worldwide. There are a few reasons. First of all, we have an elderly generation and a lower birth rate. So actually the donor population is decreasing. That's what you see on the left side. On the right side is what you're going to see the projection of the need of blood products worldwide. We have an elderly population undergoing all kinds of interventions, and we need more and more blood products. So it's another reason not only to think about is it good for the patient, but also where are we going to use our scarce blood products. So enough reasons to start thinking about a trial. So to recap, transfusion guidelines, they differ quite a lot. They've been moving from the past of having a threshold of 50, going down already, some of them in the world to 20, because they were thinking, well, it's probably safe. Ultrasound guidance has greatly reduced CVC placement complications. Transfusion reactions are common, often underdiagnosed and underreported, and we have a scarcity of blood products already, but in the future even going more. So are prophylactic platelet transfusions really necessary to prevent CVC-related bleeding complications? So this was our hypothesis, that omitting it, because this was also the flow we are all in. If we just use ultrasound and we are experienced, it will not increase catheter-related bleeding. So this is what we did. We did an initiate a trial, multi-center, 10 hospitals in the Netherlands. We enrolled ICU and hematology patients on both wards. It was single-blinded. We tried to blind the operator as well. Not in all hospitals it was possible that one of the persons was randomizing and the other was not knowing which arm the patient had, but it was possible in most of them. We did a non-inferiority trial with a marginal relative risk of 3.5. It was a 1-to-1 randomization. It was quite pragmatic. We used 1 unit prophylactic platelet transfusion compared to no prophylactic platelet transfusion. You see, we have a randomization of 411 catheters with no transfusion 203 and transfusion 208. We excluded a few because of no deferred consent. In the ICU, we were allowed to do the practice under deferred consent, and a few of them withdrew consent. In intention to treat, we had 393 catheter placements, and per protocol, we had 373. What were the in- and inclusion criteria? An age above 80 years, of course, the need for a CVC placement, a platelet count between 10 and 50. It was allowed if a patient had below 10 to give one platelet transfusion, and if it was still between 10 and 50, it could still be randomized. An INR below 3, informed consent for the hematology ward. In the ICU, we were enrolling under deferred consent. There should be ultrasound-guided placement, and there need to be presence of an experienced operator of at least 50 CVC placements on a track record. Exclusion criteria were use of therapeutic anticoagulants, but for example, unfractioned heparin or low molecular weight. If it was stopped in time, patients could be enrolled. Contraindication for platelet transfusion, history of coagulation, factor deficiency or bleeding diathesis, and previous randomization in the past 24 hours, because that was conflicting with the primary endpoint. So the primary endpoint was a grade 2 to 4 bleeding 24 hours after CVC placement. And we did a modified score because the general WHO score is quite broad, and I think it's very important to focus on the intervention you're looking at. So grade 0, no bleeding, grade 1, oozing, hematoma, requiring compression for less than 20 minutes, Grade 2, more than 20 minutes compression or rescue platelets. Grade 3, requiring surgical interventions, red blood cell transfusion, really because of the bleeding, so not because of the patient was having like a hemoglobin of 4.3 to start with and then 4.2 afterwards. We corrected for that. And grade 4, fatal bleedings or hemodynamic instability requiring red blood cell transfusion. Secondary outcomes we looked at: grade 3-4 bleedings, grade 1 bleeding, hematoma, hemoglobin levels, platelet counts, other transfusions, transfusion side effects, ICU length of stay, hospital length of stay, and hospital mortality. And of course also we did an economic evaluation about cost. So baseline characteristics, very well balanced, age, I think reflecting the population, BMI also, platelet count, well balanced between the two groups, INR as well. What I think is very interesting and well balanced is that we have well representative from the hematology and the ICU ward, so we really can extrapolate those data. The other thing I think is great that we were also able to enroll a lot of large-bore tunnels like dialysis catheter, tunneled catheters, and I think most lovely is that we found enough sites that were willing to randomize those patients with platelets of 10 for subclavian vein. So we have really a representative population of internal jugular vein, subclavian vein, and femoral vein. So this is the primary endpoint. What you see, surprisingly for us, is that there are indeed more transfusion-related bleedings in the no transfusion arm. So the non-inferiority, what you can see, the margin was not hit, so we cannot conclude it's non-inferior. Even in a post-hoc analysis, we see transfusion is superior. Here you see it in this plot with the relative risk. We also look at the subgroups, and what you see, and this is, I think, important also to understand what should we do with the results in practice. The observation is definitely in the hematology ward. We see it less in internal jugular vein, and we see also the relation with the platelet counts going down is a more favor for transfusion. Here you see it in the bleeding numbers and the relative risk regarding platelet counts. You see the risk going up if the platelet going down, which makes sense. So there is a strong relation. So we also looked at the more severe bleeding. So is it just this oozing, this manual compression? No, also in the more severe bleeding, you see this signal. So it is really associated with this no transfusion policy having an increased bleeding risk. Other secondary endpoints, we see it also here. So grade 1, it's the same, the hematoma. The rate of red blood cell transfusion is the same. Hemoglobin levels are also equal. Other secondary endpoints, what makes sense, of course, in the no transfusion arm, there is more platelet transfusion within 24 hours after randomization. You see the platelet count after 1 hour is really nice. The effect of the transfusion. So although we were quite pragmatic with just giving one platelet transfusion, we were able to put it on the 50 plus platelet prior intervention in the transfusion arm. There were more allergic reactions, acute lung injury, length of stay, if you cannot say anything about it, but if there is a signal, it seems a bit more in the transfusion arm, and no effect on mortality. If we look at the rate of platelet transfusion within 24 hours, so if you have a very low platelet count, you see that the rate is going up in the no transfusion arm. And I think this is also important to take in mind if you have a patient in the hematology ward with a very low platelet count needing a CVC placement, you just should give your platelet transfusion prior to CVC placement. If it's a bit higher, and definitely when it's in the ICU and you want to have a jugular vein CVC, you can just, I would say, take the risk. Because that's the other thing we need to take into account is the cost per catheter placement. So you get a cost reduction of $410 by omitting the platelet transfusion. This is taken into account the side effects, the additional transfusion of the bleeding. So this is the difficult question. I think this is something we need to discuss in the guideline, and we also in local practice, what you prefer. So you can have a little bit increase of bleeding overall, but it reduces your cost by $410. So omitting prophylactic platelet transfusion results in more CVC-related bleeding. The other thing is what we notice is in the observational reports, bleeding risk of about 1% were reported. So what you see here in a prospective study, those incidents are very underreported and underdiagnosed. So the reporting in the patient record, which often was being used for the observational studies, are very poor. And what we had here were research nurses were really fully looking at those patients during the CVC placement and the follow-up after 24 hours. CVC-related bleeding risk is proportional to platelet count. CVC-related bleeding risk is higher in hematology wards and with tunnel CVCs. Omitting platelet transfusion results in a significant cost reduction of $410. So most of the post-CVC platelet transfusion were given in the lower platelet count groups. So what should we do? Of course, I'm happy to have a discussion about it here, but I think we should consider prophylactic platelet transfusion with platelet counts below 30. You could consider going lower when you're in ICU, and definitely when you have a jugular vein placement of your CVC, and a low threshold for therapeutic platelet transfusion in that setting, considering a higher threshold for tunneled CVC placement. This was a huge effort, a huge team effort, and it was a long journey to enroll those patients, but I think we have been able to give answer to a clinical relevant question. Thank you very much.
Thank you, Alexander. Let me start with one question. Any risk groups that you could identify who were more prone to bleed than others?
Yeah, so this is of course what we are looking at, but in that way it's the patient with a bone marrow deficiency due to, for example, chemotherapy, hematologic, those have non-functioning platelets. They are most at risk, while the patient with a sepsis in the ICU has a different origin of the thrombocytopenia and is able to, it seems from the study, to handle an intervention with a very low platelet count.
Congratulations, that is a game-changing study, and you should be very proud of all that hard work that you've done. Just picking up again on the hematology patients and their lousy platelets compared with sepsis, do you really think that the new target you're suggesting is appropriate in hematology patients?
Yeah, so we need, of course, to look, if you look at this very low platelet count there, it doesn't seem to be the highest risk. It's going up a bit higher there. Why, we don't understand why this observation is there, because between 10 and 20 the risk is a bit lower of bleeding, while it's going up between 20 and 30. Why is just a confounding observation, or whether there is a different relation when you are hitting the 10 or when you are between the 20 and 30 in a hematologic setting? Maybe you have a good idea about that.
I guess it's how you measure the platelets. So I guess you used a standard analyzer,
yeah,
and you're measuring platelets by size. And if you have a lot of young platelets, they're very large, they get counted as red cells. So some of the septic patients may have a true platelet count that's greater than the one that you have.
Could be.
Know. Yeah.
More questions from the audience? If not, then I have another one. How did it change your practice? How do you do it now with this
So we
results?
just really got the results out there. So this is the first time we present it. So I think we will take the approach we were also suggesting, and I'm of course looking in the ICU, that if we have a CVC placement in the jugular, we will lower the threshold to 20 or 30 in experienced hands. So I think this is also an issue that in many ICUs maybe the physician is not yet experienced. But then I think, and this is I think the future, how we should look at, we should not make the patient ready for the physician, but we should make the physician ready for the patient. So we should take a personalized approach that a patient with a severe thrombocytopenia or a coagulation problem, not the junior doctor should do the intervention, but the more senior. Because I think with the scarcity of blood products, the cost reduction, we should not give blood products because we have an inexperienced person.
Right. There's one more question.
Yes, I was just wondering whether or not you guys would think the utility of using a TEG when you're right on the cusp of your goal, platelet goal, whether using TEG to look at the functionality in guiding your therapy, especially when you are, in an institution where you can't really get platelets or get your blood products as readily.
Sure, but then I think there is already a cost aspect of $410 reduction if you do not transfuse. In a huge group, I think you can identify where it's safe. Maybe in this small group, you could be doing additional testing, but then I think in a lot of centers there is no viscoelastic testing or TAG capacity to do those platelet function testing. So I think this is an additional cost, of course, for doing such a test. So it could be an additional sub-study.
Thank you.
All right. Thanks, Alexander, for this nice talk. Let's applause. Okay, next one. Beverly Hunt, King's College London, is going to tell us about if and how to reverse DOACs.
Well, thank you very much. I'm here to talk about DOAC reversal. I'm showing a picture of my hometown, and my office is on the right, and I look out over our terrible government every day in despair. I should also say that as I passed through the tunnel in the Eurostar, my laptop got very, very hot and started emitting smoke, and my original talk was destroyed in the Eurostar. I suppose it was complaining about coming to Europe after Brexit. So I have had some help from Professor Marc Maegele in Paris. He's lent me a number of his slides. So really I should be showing you a picture of the Seine as well. Anyway, on to the subject, no conflicts of interest. And so we are now using vast numbers of direct oral anticoagulants in our elderly patients, particularly who have atrial fibrillation. They have taken over from warfarin in most of Europe. And when we look at the major bleeding rates, we have apixaban slightly lower than the others, and we know that they bleed. About a third of them will have a GI bleed, and unfortunately 10 to 25% will have an intracranial hemorrhage of those bleeds. But this rate of bleeding into the brain is much lower than warfarin, which is why we are using these drugs. And there is hope coming through because there are now trials of agents that have an anti-11A effect that are coming through in the next year or two that have a lower bleeding rate with the same benefits of thrombotic prevention. Looking at the pharmacokinetics, they've got similar pharmacokinetics, so short actions. And so let's get down to it. If we have someone come up to the emergency department with a bleed, we are going to go through our conventional practice of taking a history, examining the patient, and finding out which DOAC they may be on, hopefully get a coagulation screen. We want to know the creatinine because all of these drugs are excreted renally mainly. Look at the liver function test, and we would like to get a level of the DOAC in the laboratory. And we may or may not want some hematology expertise. The problem is that if we talk about patients with massive bleeding who are on a DOAC, we are a little bit in trouble because the DOACs will change the coagulation screen that guide us in how we manage our patient with the use of blood products. So we know with the anti-10A agents, they can prolong PT-APTT, and dabigatran has a major effect on those values. It will also affect the thrombin time and functional fibrinogen. So it will interfere with how we manage our patients. And then there still are a few patients around on warfarin. We can't escape those with mechanical valves. If we've got warfarin, we're going to use vitamin K and PCC. And then we have some specific agents for the dabigatran, which is idarucizumab, or we have for the anti-10As, adexanet. And adexanet not only will reverse our rivaroxaban, edoxaban, apixaban, but also will reverse, and it often gets forgotten, fondaparinux and all the low molecular weight heparins. So quite a useful range of effects. And of course, if we've got massive bleeding, we'll follow the normal protocol for resuscitating the patient. Now, I think where we aren't doing so well is what's happening in the laboratory. It's a medical emergency having someone with an intracranial bleed on a DOAC, and really we want blood levels. So we want anti-10A levels if they're on an anti-10A agent, ideally one of the functional assays, and we want it quickly. And then we would like a dilute thrombin time for dabigatran. Now, I personally run a group of laboratories, and it is a prerequisite that in those laboratories, if we get somebody, we need an urgent level, they turn it around very fast, and you can get the level back on the electronic system within the hour. The other thing to say is that the problem with the anti-10As is that they will affect the clotting tests in a very random way apart from rivaroxaban. So the amount of rivaroxaban you have in your blood will increase the PT in a linear way, but you can have a normal PT and still have quite a lot of apixaban and edoxaban around. So the big question always is, do you actually need to reverse your DOAC? Because it does have a short half-life. If you've taken the drug 24 hours ago, really there isn't much need unless you have got somebody who's got renal failure or renal problems. There is an argument if you've had your drug recently to give activated charcoal. It does actually help clear the drug. So we need to go through the two direct reversing agents. And we have idarucizumab, which is just a monoclonal antibody, which has been humanized, and adexanet, which is a very clever molecule in that it's a recombinant truncated form of factor 10A. So it's a decoy molecule. If we look at idarucizumab, it binds to dabigatran and pulls it out of the circulation, neutralizes it. And we know from the clinical trials it's effective in doing that. When we look at the trials, it works well, but the background rate of death is still high. And that's because the patients are coming to you and they have already had the event and there's continued bleeding until they get this agent. So we're still talking about mortality rates of about 18%. With idarucizumab, you're giving 5 grams fairly quickly, but you need to keep repeating the dose because the effect wears off. So after the first dose, you need to continue to monitor either with an APTT or a dilate thrombin time, and perhaps give another dose. This slide I put in not realizing what was going before, but you can, if you run into problems with dabigatran and probably not suitable for managing massive bleeding, use hemodialysis, because it will remove about 50% of the total dabigatran if you're in trouble and you have somebody who's got renal failure. I've only really used it once or twice, and it was a desperate act to get rid of dabigatran in patients who had renal failure and high levels and continued bleeding. Then we've got Adexanet, so this decoy molecule. It's very cute, very well thought through. We've got the decoy molecule, and it will capture the drug and remove it from having any activity. And the trials, and these are all quite old now, show it's effective. The bigger the dose you give, the better the removal. And anybody who's recently had an anti-10A agent within the last 7 hours of a reasonable dose should receive the higher dose of 800 milligrams, and then everybody else should have 400 milligrams, and then afterwards have an infusion. And again, we may need to repeat, because this is a short-acting reversing agent, and levels may reaccumulate again. This is from some of the original work. You can see at 4 hours, it's the levels of anti-10A are starting to drift up again. The other issue with Adexanet in the original trials was that there was quite a high residual rate of thrombosis, and this was a worry. Of course, we are reversing anticoagulation in a group at high risk of thrombotic events. So they have a high background risk anyway. Is it that using Adexanet is giving us further problems? Now, this is an editorial that I wrote with is an international group of us looking at the reversal of anti-10A agents in trauma, because there still are no trials of using Adexanet in trauma. And in the US, it's incredibly expensive when you compare it with using PCC for reversal. And so the argument at that time was, and I think it's still true, we've managed without Adexanet by using PCC to reverse the anti-10A agents. They do appear to reverse the bleeding effect, reducing a bleeding effect in intracranial hemorrhage and GI bleeding. So for the moment, until we know more about Adexanet, and there is a trial going on looking at its use in trauma, we should be ideally in our trauma patients measuring the anti-10A levels. We can give PCC at the normal dose of 25 to 50 units per kilogram or Adexanet and continue to monitor, and then continue with our standard management of trauma, TXA, blood products, and goal-directed therapy. And again, we've got this problem. We've got a DOAC in a profoundly bleeding patient with trauma, and we've got prolongation of some of the clotting tests because of the agents we use. It's true for vitamin K antagonists. We haven't validated the anti-10A assays in traumatic coagulopathy. And so there's interference with measuring the traumatic coagulopathy that we have underneath. And the worst case scenario, of course, is an unconscious patient who's arrived. We know they're on an anticoagulant. We don't know which one. We need to have a fast turnaround anti-10A and direct thrombin time to have a look underneath to see what is going on. We do have DOASense. So DOASense came out in 2018, and we can dipstick the urine to see whether there is an anticoagulant there, and it'll tell you whether it's an anti-10A or an anti-2A. But really the elephant in the room is I've told you about these beautifully designed, specific antidotes to the DOACs. Are they actually appropriate to use, or could we use PCC, which is much cheaper and where we have got quite a body of evidence? And the answer, well, what's best for 2023 is this meta-analysis that came out in 2021. It looked at all the papers, so 60 papers. There were over 4,000 patients who were bleeding on a DOAC, and 2,600 got PCC, over 1,000 got ISICEM, and nearly 1,000 got Adexonate. And this summary slide is very clear, really, because when you look at the death rate, you've got this background death rate, whichever one you use, about 17 or 18%, not very different between PCC and the specific reversing agents. Looking at the thromboembolic rate afterwards, there's a slightly higher rate with Adexonate. And then, did these agents achieve effective hemostasis as judged by the surgeon and the hematologist? And we're looking at rates of about 80%. So for the moment, we still don't have enough evidence to say we should definitely be using the direct agents over PCC. This is looking at the use of the drug versus not using any reversing agent. And what this does show is that we should be using a reversing agent, otherwise we won't get effective hemostasis. So what am I saying now? I'm afraid there's not much new in this field, and we need some more studies to take us forward. And it's quite surprising how little research there is here. We have a number of tools now to reverse DOACs, and we have to pick the right tool for the right patient and their location and the severity of the bleeding. And really, we need people to go away from here and look at reversal of DOACs with fresh ideas and with a new research agenda. Thank you.
Thank you very much. Alexander, straight with the first question.
Well, thanks for the great presentation overview. What triggered me was also your start, where you were saying and announcing already the new agents, the factor 11 inhibitor, which is great they are coming. But on the other hand, your call for doing research on the antidotes now, how fast do you think the field will be moving to the factor 11 and the areas where it will have a place? Because the first results look very promising. And what would that mean for the reversal research?
So when you have a new antithrombotic agent, the first place you go is to hip and knee replacement, because it's a beautiful model and you can compare against the standard of care, which is usually low molecular weight heparin. And when we look at the anti-11A drugs, they give lower rates of thrombosis and lower rates of bleeding at quite low doses. So this is really exciting. We haven't got any results of any trials in patients with atrial fibrillation. They are ongoing. We're looking at cancer patients as well, because they're a group where DOACs have benefit, but they do cause a bit of gastrointestinal bleeding in those with adenocarcinomas. So I think we're talking probably about 5 years. So there is this gap, and we do need some more work on these agents.
More questions from the audience? If not, then thank you again for this wonderful talk. And we move straight on, since we have the discussions in between. Monsieur Pierre Bouzard from Grenoble, the stage is yours.
Thank you. Ladies and gentlemen, good morning, dear colleagues. So it's a pleasure to present the data regarding 4-factor PCC, and we have new data regarding this therapy that has been published on Tuesday in JAMA, so I will present also the results of the study. So I have a few conflicts of interest to declare regarding this presentation. And to introduce my presentation, I would like to start with the European guidelines. And as you can see here, the 4-factor PCC has been proposed as an alternative to FFP transfusion and provided different conditions. The first one is provided that you have normal fibrinogen levels. And the second thing is that you should have an evidence of delayed coagulation initiation using viscoelastic methods. So it means that the administration of PCC is closely linked to the use of viscoelastic method. And for sure, in many centers, viscoelastic method has been adopted. And as you can see here, one of the routine-based algorithm for treating patients. This is the algorithm we use in my center. We also use the same algorithm in Lyon. And as you can see, there is a stepwise approach where first we assess the fibrinogen level with FIBTEM, and then we look at the coagulation time in EXTEM, and then maybe we can give FFP or PCC. So what about the history about PCC? So I think one of the first landmark study about PCC in trauma patient is an experimental study. It was in a porcine trauma model. So what they perform is historical, I would say, hemodilution with the retrieve 70% of blood volume and then replace the blood volume by colloids and RBC. And you can see that they treated before the injury the animals with saline solution, FFP, or 25 international unit per kilogram or factor 9 of PCC. And as you can see, the number of animals that achieve hemostasis was higher when they were treated with PCC. They look also at the blood loss, and you can see here that the blood loss was lower in animals that were treated with PCC. Obviously, this is experimental design. The treatment was administered before the injury, which is pretty unusual. And the hemodulation is very historical because it was replaced by colloids and RBC, and it was a large replacement of the plasma by colloids. Several studies also have shown possible interest of 4-factor PCC, mainly coming from Austria at the beginning of 2010. And there are several retrospective studies, several reports that have shown that maybe a combination of coagulation factors concentrate, a mix between fibrinogen and 4-factor PCC, may decrease total blood product consumption. Here you have one of these studies. You can see that in patients treated with fibrinogen plus PCC, you can see that there is a decrease in total blood product consumption, and you can see the increase of patients without any red blood cell transfusion even. So based on this rationale, some countries decided to adopt a concentrated coagulation factor concentrated strategy to treat the patient. This was the case, for instance, in Germany. This is the kind of algorithm you use. And you can see that using coagulation factors concentrate strategies, they reduce also, comparing 2 periods of time, the number of red blood cells that were transfused in the emergency department. And obviously, this is quite interesting, and also the FFP decrease, but I think one of the major limitations of this study is that they compare two periods of times, and I'm pretty sure that at the early beginning of the 2000, we were treated patients differently than in this period of time due to the improvement in interventional radiology, for instance. So this was a retrospective analysis comparing two periods of time. It was not perfect. The other thing is that if you look at what they should probably can give to the patient, you can easily guess that the most severe patient would have a combination of all blood products, meaning all therapies, meaning that you have a combination of FFP plus PCC sometimes in those patients. The first randomized controlled trial, what was performed comparing FFP versus coagulation factor concentrate, was a RETIC trial that was published in Lancet Hematology. This was a single center study with an open label drug. And as you can see, that was a decrease in the proportion of patients with massive transfusion in the group of patients that were treated with a coagulation factor concentrate. But if you look into details, you can take the numbers of patients that were treated with 4 factors PTC was very low, and all patients were treated with fibrinogen. So basically, the RETIC study is a study regarding the use of fibrinogen. And only a minority of patients were treated with 4-factor PCC. And as well, if you look into details, you can see that even in patients treated with coagulation factor concentrate, some patients will still have fresh frozen plasma. And so recent evidence also comes from the US, where they look at a registry, trauma registry, and they compare patients that were treated by 4-factor PCC plus FFP versus FFP alone. And what they found using propensity score is that was a decrease in total blood product composition at 24 hours and a slight and statistically significant overall in-hospital mortality. And in another study, they also look at the thromboembolic complication, and they did not find more thromboembolic complications. Because the main concern regarding the use of 4-factor PCC above its efficacy is obviously the safety of the drug. So the rationale is here, and so we decided to conduct a randomized controlled trial, which is a PROCOAG randomized clinical trial that was published Tuesday in JAMA. So what we've done is a multi-site double-blind superiority randomized controlled trial. We used 2 arms. One arm was treated with 4-factor PCC at the dose of 25 international units per kilogram, and the other arm was treated with placebo at the dose of 1 milliliter of kilogram of saline solution as soon as possible in the trauma bay. Both arms were treated according to European guidelines with early administration of tranexamic acid, ratio-based strategy, and fibrinogen concentrate based on fibrinogen concentration or viscoelastic evidence of fibrinogen deficiency. The study took place in 12 level 1 trauma centers, and we included adult patients admitted after severe trauma, directly admitted from the field to the trauma center, and at risk of massive transfusion. So we define massive transfusion by the transfusion of at least 1 part RBC in the hospital field or within first hour after admission in the trauma bay, and an ABC score for assessment of blood composition score higher than 2. And the physician, the investigator, could override the ABC score criterion if the clinical judgment was in favor of risk of massive transfusion. The primary outcome was the number of total blood products units mixed between RBC, FFP, and platelets transfused at 24 hours after hospital admission. The sample size was calculated at 324 patients who observed a reduction of 24-hour total blood composition of 25% from 12 units to 9 units. We also look at different secondary outcomes. We look at the separate analysis of the individual blood component units, the time to a PT ratio lower than 1.5, time to hemorrhage control, 24 and 20-day mortality, number of ICU-free days, number of ventilator-free days, number of hospitalization-free days, hospitalization status at day 28, and the GOS extended in patient with traumatic brain injury. Regarding safety, we look at arterial and venous thromboembolic events, and they were recorded through day 28. So this is the flow chart of the study. The third thing is you can see that only less than 10% of the patients were eligible for the study, which means that patients are quite rare. And among these 350 patients eligible for inclusion, we finally randomized 327 patients. 165 patients randomized to receive 4-factor PCC, and 162 were allocated to the placebo group. 1 patient with due consent, 2 other with due consent, and then we analyze this in the intention to treat analysis. 164 patients in the 4-PCC group and 160 in the placebo group. So here are the patient characteristics. As you can see, the typical patient was a young male admitted after blunt trauma. There was a slight imbalance of systolic arterial blood pressure, and it was higher in the pre-hospital field in the 4-PCC group, but on arrival on the trauma bay, the systolic arterial blood pressure was the same. We also have an imbalance in tranexamic acid infused, that is due to other, but you have 86% of patients treated with TXA in the placebo group versus 76% of the patients treated with TXA in the 4-PCC group. But globally, they have similar baseline characteristics. There were severe patients with a high traumatic load. As you can see, the median lactate concentration was 5 millimole per liter on admission. 1/3 of the patients had a fibrinogen lower than 1.5. We observed acute post-traumatic coagulopathy in 2/3 of the patients. The median ISS was 36 in totality, and the proportion of patients with traumatic brain injury was 1/3 of the patient. Regarding resuscitation indicators, the patients also were mostly severe, with majority of them requiring hemostasis control procedure. The transfusion of at least 3 units of PVC was around 40%, and more than 10 units was 25%. And the proportion of patients treated with fibrinogen concentrate was the same between the two groups, and you can see that was a slight imbalance, but it was not clinically significant in terms of total dose of fibrinogen concentration between the two groups. So here are the results. There was no statistical nor clinical difference between the 4-PCC group versus the placebo group in terms of total blood product consumption, that we have 12 units in the 4-PCC group versus 11 units in the placebo group, a p-value of 0.72. When you look at the separate analysis of the blood products, you can see that there was also no difference. And if you look at the time course of the PT ratio, the time course was not statistically different, even if the 4-factor PCC group, we observed a faster correction of the PT ratio, but the PT ratio was not different at 24 hours. And the time to PT ratio lower than 1.5 was similar between the two groups. Obviously, the same results was observed in the per protocol analysis, and this is a subgroup of patients with massive transfusions. That was a subgroup that was specified before the study. Regarding safety, we found more thromboembolic events in the 4-PCC group versus the placebo group, with an incidence of 35% of patients with at least one thromboembolic event in the 4-PCC group versus 24%. And we look at the proportion of patients with thromboembolic events according to their PT ratio status, below or lower than 1.2, and we found that patients with a PT ratio higher than 1.2 are more likely to have a thromboembolic event in our study. The 24-hour mortality was not different between the two groups, and the 20-day mortality was not different also between the two groups, and there was no difference for other secondary outcomes. So just to conclude it, to explain, I think one explanation for the results is probably that the thrombin generation is not altered after severe trauma. And we know that thrombin generation is an essential step for the coagulation cascade because it will create fibrin thanks to fibrinogen. And there are several experimental studies that show that after trauma, we lose activators of coagulation, activation of the coagulation cascade, but we also lose inhibitor of the coagulation cascade. And this may result in a new hemostatic balance, and the thrombin generation may be activated and exaggerated in these patients. So to conclude, we should have massive transfusion protocol in the trauma bay, for sure. This is one of the main important points. But PCC plus FFP was not superior to FFP alone to correct PT ratio in patients with massive bleeding. And PCC increases the risk of thromboembolic event. So PCC should not be used systematically in bleeding patients at risk of massive transfusion. And the remaining question is, what about PCC administration guided by VET? Because we've seen more thromboembolic event in patients with a high PT ratio, it's questionable whether we should not use as well PCC in this population, even guided by VET. Thank you for your attention.
Congratulations for the study and the publication. Clear result, clear answer. We move on to
disappointing
the next,
result.
Questions from the audience, Alexander.
Yeah, so congratulations, great job. We've got a question about where the other transfusions are given, because in a way it's of course great, it's double blind, but on the other hand, because it's double blind, people probably in your sites were giving ratios, what you were saying, and so in the beginning they're just transfusing and there is not yet a feedback. So was there a chance to have a different transfusion outcome? Because the majority of the blood products are just given in the first hour, for example, and as they were blinded, they were probably going to give the same.
That's a good point. The thing is, I think it's true for the beginning of the treatment, for the first hour. But as soon as you adapt your transfusion, then you can use the coagulation test or the viscoelastic test. You may use viscoelastic testing in the study. So you may adapt.
But do you have analysis to look at the time there was a feedback of the first lab results and whether the behavior or the policy changed then?
No, we cannot have you said several time points where you can analyze the transfusion rate. I would say no, we don't have this information.
Would be interesting.
Yes, for sure.
Further questions from the audience? I do not see any. Thank you very much. We move on to the next speaker. Michael Reed from Brisbane made the entire way. To tell us if it shouldn't be whole blood instead, right?
Indeed. Well, that is the question. So you've just heard a brilliant presentation of a really definitive trial looking at factor concentrates. And indeed, before that from Pierre, an overview of the question of whether factor concentrates have a place as opposed to a ratio-based strategy. But there are people around the world, colleagues around the world, I have to say American colleagues in particular, and even amongst their military colleagues, who would say, well, this is not a relevant question. That the more relevant thing, by far the better thing to do is to just say, well, yes, that balance of pro and anticoagulant activity that we've just heard about, far more better served by using whole blood. So is it as good as those people say? Well, I always like to answer the question at the start, and my answer over the next little while will be to convince you that it's not yet possible to be sure, but there are a number of studies in train that will make it soon possible to know the answer to that question. So you have, this year, published in Europe resuscitation guidelines for major hemorrhage in trauma, and I'm going to speak specifically about trauma. Curiously, they start with balanced crystalloid solutions, but in major hemorrhage adopt either a factor concentrate or a ratio-based approach. But that's quite different to American military guidelines, for example, the Tactical Combat Casualty Care guidelines here, that start with whole blood. interestingly, they start with cold, stored whole blood in preference to fresh whole blood, largely for logistic reasons. And they don't mention crystalloid at all for a patient in hemorrhagic shock, only one who's relatively stable. And there's a lot of enthusiasm, as many of you may know, for whole blood in trauma resuscitation in the United States. This is a paper published by John Holcomb and others, lamenting the fact that only about 24% in 2020 of American trauma centres had whole blood available in their trauma bay. And commenting, potentially maybe extrapolating the evidence a little far, that this highlighted a gap between evidence and practice, that this figure should have been 100%. So my question, or my goal in the next little while, is to tease out whether in fact that was a justified comment. We've just written our Australian transfusion guidelines in trauma. We don't have whole blood like much of you in Europe, and so we prioritised a ratio-based approach over both concentrates, factor concentrates and whole blood. I'm not going to tease apart the relative arguments between ratios and goal-directed therapy. I'm going to concentrate on whole blood in this presentation. When we talk about whole blood, it's important to understand that we're not just talking about one entity. We have to distinguish, first of all, the context in which it's being used, because use in hospital, when we're looking at trials, usually means comparing whole blood to use against products or factor concentrates that are guided by laboratory values, perhaps point-of-care testing, and the whole range of other transfusion interventions that might be available, as opposed to pre-hospital use, where we don't have those laboratory values, and potentially the comparator is just crystalloid, or potentially it is red cells and plasma, but it's certainly not platelets. And so those two contexts are very different and will potentially lead to different results. We also have to distinguish between what we're now calling an emergency donor panel and a walking blood bank. So an EDP is where you take blood from a patient, from a donor, and you know the patient that it's going to be transfused into, and it's given fresh. Whereas a walking blood bank is where you take blood from a donor, but you don't know the patient that it's going to be transfused to. And that might still be given fresh within 24 hours, but more typically it's given stored within 14 days, most conventionally, but sometimes up to 30 days. We also have to distinguish between type-specific whole blood and low T to O, or universal donor whole blood. For decades, we've been giving type-specific whole blood because we know that although group O red cells are the universal donor, it's group AB plasma that's the universal donor because it lacks all antibodies to ABO antigens. And potentially group O donor blood has antigens to A or B or both. But we now know from really a lot of epidemiological work that in practice only about 5 to maybe up to 30% of donors have clinically significant levels of antibodies if they are group O, and so they can be considered universal donors as long as there's the ability to titer their antibodies prior to the donation of that blood. So we call this a low T to O donor program. And it's that's, I suppose you could say, taken a hold in US trauma thinking and really where the majority of the trials are now assessing efficacy in whole blood. Is there a difference between type-specific and low T to O? Well, we used to think possibly there was. This is a study from, well, now 13 years ago, that did show a dose-dependent deleterious effect from increasing amounts of compatible but non-ABO identical plasma transfused. A relatively small study though, and one which has been, you might say, superseded by this study that was published a little more recently in a much larger study. And it's one that's a little complicated to walk through, but essentially I'll try to get you to understand that on the x-axis there is injury severity with higher injury severity towards the left there. And although it's a non-significant relationship, those marks on the y-axis show that there's a trend towards more complications with more incompatible, ABO incompatible blood, or non-identical rather, not ABO non-identical blood that's compatible, and so essentially equivalent of low T to O. So people have argued this two ways. One is to say, well, that's a non-significant trend, therefore it doesn't matter. Other people have said, well, it is a trend, and so perhaps we should take some attention to that. So the bottom line is probably that in a hospital with a laboratory, type-specific or cross-matched whole blood might be clinically better. There's a non-significant might there. But it would definitely increase the size of the donor pool, because you could use people other than type O. But of course you have to then titer their antibodies, so it would be slower unless you'd pre-registered the donor pool. But anywhere other than a hospital with a laboratory, like for example a forward military hospital, or in the pre-hospital environment in a helicopter or ambulance or so on, where none of those things are available, low titer O would be preferable to presumably any alternative like crystalloid that would be available there. What about the question of fresh versus stored whole blood? Do the clotting factors, do the platelets become affected by time in storage? Well, they do to a degree. So you might not be able to see the detail of this graph, but on the left, as you look at it, the platelet count, and that diminishes over the 31 days of storage that are seen there, but not to critically low values. And in fact, in storage, the platelets do seem to become, in a sense, pre-activated. So the platelet function seems to increase as their count decreases. And then in the graph on the right is the TEG result, or a TEG result, showing coagulation function, which is essentially preserved up to at least around 10 to 14 days, which is why conventionally we say that whole blood can be kept for about that long. And as you can see there, many people are advocating storage for up to around 30 days. Of course, this is a moot point in much of the world. In most of the developing world, whole blood is the only alternative because there aren't the resources to fractionate it. And indeed that is true currently, about 2,000 kilometres from here in the conflict in Ukraine, where recently a panel of us were told that the vast majority of blood is just not able to be fractionated. It's being given as type-specific, interestingly, whole blood, essentially at the point of donation. But let's look at the evidence for superiority, if there is any. This is the study that people will commonly show to try to convince people that, in fact, whole blood is superior to component therapy. It was done in Iraq by the US military at a time when type-specific blood was the only option. And as you can see, there's an enormous mortality advantage associated with warm, fresh whole blood compared to component therapy, an odds ratio of 12. You were 12 times more likely to survive if you got whole blood. That's fantastic. How could that be? How could there be such a profound mortality effect? Well, even though that was adjusted for severity of injury, I think this is what was happening. To get the fresh whole blood, the donor had to be called in, which would take time. They had to have their blood taken, it had to be typed and cross-matched, and then it had to be transfused to the patient. And that would have taken, well, I've done this, it would have taken at least 40 minutes to an hour, probably a bit longer. And so you had to survive long enough to receive the whole blood, whereas if you were going to receive component therapy, that would have come directly from the blood bank. So there was a survival bias that explains that result, I think. Interestingly too, the comparator in that study was component therapy that just had plasma and red cells, not platelets. And in this study by the same group, when they added in the comparator that included platelets, the mortality advantage disappeared. So I've kind of become a bit of a heretic in pointing this out as I go around the world with my US colleagues arguing the contrary. But I think that this is probably true. That study overstates the case. So what is the, you might say, the good evidence for whole blood? Well, let's tease it out into pre-hospital versus hospital. So there's this study of pre-hospital stored whole blood, a study of 200 odd patients, propensity matched. But the propensity matching wasn't ideal. It was done on on-scene vital signs, and it excluded a whole lot of people. But it did show a mortality advantage from receiving whole blood compared to not receiving whole blood, and those people might have actually received nothing. This study, again from the US military, looked at people who went to a small surgical hospital, a Roll 2 hospital, showing an odds ratio of 0.15. So again, nearly 10 times more likely to survive if you received whole blood pre-hospital. And again, seemingly a convincing study of more than 1,000 patients, but is an odds ratio of that much biologically plausible, would be my question. There's been one trial, clinical trial of pre-hospital whole blood, this one from the United States, a small study showing safety but no clinical benefit. And this is being spun out now into the much larger LIGHTS network study of pre-hospital whole blood, looking at mortality, 1,000-odd patients, and we will know the answer to this within the next few years. Hopefully. The possible criticism of this study is that the transfusion limit will be 2 units of blood, and whether that will be enough to show an effect, I suppose, only time will tell. We're also hoping to do a trial of pre-hospital whole blood in Australia, joining with the SWIFT study that's, if it's not already started to enrol, will start enrolling in the United Kingdom. So a British study that we're hoping to add patients to in Australia, thinking that Australian pre-hospital times in particular might be of particular benefit. So what about hospital studies? Well, this is a meta-analysis of hospital studies that really showed that Spinella study that I showed you from the US military as an outlier, but really didn't find a lot of evidence for the hospital use of whole blood in any other context. And a similar meta-analysis concluding no net benefit. And these were published about 3 years ago. There have been a few studies since, this one from paediatric practice in the United States, showing benefit from whole blood, stored whole blood, a propensity analysis in children. But one might wonder whether 56 children is enough to be really sure to change practice. This another propensity study from the United States, again cold stored whole blood in hospital practice, published last year, but some questions around the propensity matching. And curiously too, the vast majority of these patients only received 1 or 2 units of whole blood, and yet an enormous mortality difference. And again, we have to be careful when looking at the biological plausibility of these results when analysing these retrospective studies. This is a well-performed retrospective propensity-matched analysis from a single centre in the United States, nearly 1,500 patients, and it curiously found no benefit at all of whole blood. So there's a contrary view as well from well-performed retrospective studies. And then finally there's this one, and this is probably the landmark paper that would justify investment in a randomised controlled trial. So if there's one to take a picture of, it's this one, the Torres paper that was published earlier this year. And I'm yet to be able to really find fault with the methodology of this propensity-matched analysis from trauma patients in the United States and Canada that did seem to show a substantial benefit from whole blood transfusion as part of a massive transfusion protocol compared to component therapy in hospital. So, what trials have there been? Well, there's really only been one performed now about 10 years ago, and it's been criticised on numerous counts, amongst them that the people who got whole blood in this study had it passed through a filter that would have taken out the platelets, and so therefore it's not really a valid comparison. But curiously, the mortality effect, although it wasn't significant, in fact seemed to favour component therapy compared to whole blood in this instance, so that's a concern. But there are trials of whole blood that are currently underway. There's the French T-STORM study, looking at not a patient-centred outcome, so you might say a pilot study, looking at non-inferiority for the correction of coagulopathy. And then this, the TROOP study, which hopefully will definitively answer the question for hospital practice in the United States, that's just about to begin recruiting more than 1,000 patients. So, the final point to make is to address the question, well, look, you know, you've presented some evidence for, some evidence against. Before we know the answer, well, why don't we just do this? And the answer to that question is around resource utilisation. So our blood service in Australia have looked at just this question. And I won't take you through the detailed calculations because I haven't got time, but the bottom line is that if we're to apply the criteria that will be used if we join the SWIFT trial, that essentially every eligible donor of whole blood in Australia would need to donate 1 unit of blood every year to supply trauma patients with the required amount of whole blood. And that's a pretty substantial impact on the Australian blood supply and the blood donor pool. So could we do that? Well, our blood service at the moment says, well, we'd have to have a pretty good reason to embark on that policy. In other words, we'd have to be able to see clinical superiority in terms of outcomes. We're prepared to support a trial, well, they are. They're prepared to support unique circumstances of use, so potentially pre-hospital use. but not yet widespread hospital use in trauma or for that matter in any other indication in massive hemorrhage. So what's the clinical take-home message? At least in my opinion, the superiority of fresh or stored whole blood available in hospital is not yet proven. Pre-hospital, it's a slightly different equation, you might say, because of the logistic advantages of whole blood over other forms of component therapy. And indeed, we are moving to do this in the Australian military. I would say, in general, beware potentially flawed observational studies. And if there's the potential to enrol patients in clinical trials in your practice, please support that. Thanks very much.
Thank you very much. Questions from the audience?
Great presentation. I think you can leave out the potentially flawed observational studies because also the plasma ratio studies, they were flawed as well. They had a 66% mortality reduction, never been shown in any randomized trial. So actually, I think the ratios have never been proven in a randomized trial to be superior to the standard therapy. So the other thing is long-term outcome, because we're going to expose now maybe young female casualties, chance of antibody formation. So what's your take on that? So I think we have really a lot of safety issues still not covered while there is no zero superiority shown.
Yeah, so the question there is essentially a question around availability of O negative whole blood, which is very, very restricted. In military practice, at least the US military has decided that because it's so restricted, they'll use rhesus D positive blood. And their assessment of the balance of risk and benefits is that is acceptable for their female soldiers. I'm not going to comment on US military policy. But for the civilian environment, where there are more females than there are in the US military, it's just a fact, many people believe that that's an unacceptable risk for rhesus immunisation for the female trauma patients who would receive that O positive blood. And I can certainly see that argument unless there is clinical superiority demonstrated in other ways. And I agree with you, that's not yet been demonstrated. Yeah.
All right, thanks a lot. Then we move on to the next speaker, Nicole Juffermans from Amsterdam University as well.
I don't know about you or your ICU patients, but my ICU patients are hardly ever being run over by a bus, right? So depending on how your hospital is organized and whether or not you're responsible for the emergency department and the care of trauma patients, you may not be exposed to the burden of caring for trauma patients, yet you do care for bleeding patients. Yet all of this research attention is focused a lot on trauma, which may not be surprising because it's pushed a bit by the Ministry of Defenses or the military forces of the hospitals around the world. And while this informs us about coagulopathy and the management of bleeding, there are also many, many other patients that bleed on ICU. Let's look at these rates, right? Depending on the subgroup of patients and whether or not they have a coagulopathy due to whatever cause, bleeding requiring transfusion in ICU is very often. Also, bleeding, just being very ill, has a high rate of needing transfusion. So how cool would it be if you could predict who would bleed, the relevance of which would be that you can modulate the rate of anticoagulation or modulate the rate of prophylactic anticoagulation, right? So I will talk about ROTEM, but I will also talk about other clinical characteristics, and I'll only focus on bleeding. So I did tweak it a little bit, Chairman, but I think it fits nicely within this session, which is about bleeding, of course. So what type of bleeding do you have? ICU patients, they bleed everywhere. A lot of bleeding is in the gastrointestinal tract, but they really bleed everywhere, related to intubation, to nasogastrial tubes, but they also bleed intracranial. So a high burden of morbidity of bleeding in ICU setting. So can we predict who will bleed and who will not? Let's look at the platelets. That is the only coagulation score that is present in the SOFA, and that predicts negative outcome in ICU. So Is this a good parameter to predict bleeding? Well, yes, if your platelet count decreases, your odds ratio of bleeding increase. But the thing here is that there is no safe threshold. You cannot say, if my platelet count is above 50, you will never bleed. If my platelet count is above 100, you will never bleed. It's a line of severity, but there is just no cutoff point. So the prediction will not be very easy. What about fibrinogen levels? We also like this. It's easy measurable. A lot of ICUs do it. Does it have some predictive ability? Well, yes, in a subset of patients, it does. Here you can see cirrhotic patients, and there are a number of measures here, all related. Again, the platelets have no predictive ability, but fibrinogen has, with a very high negative predictive value, meaning that if your score is above 1.8 grams per liter of fibrinogen, you're not very likely to bleed. But this is a very specific subset. And the other thing is, in the same cohort of patients, the cutoff level found was much lower. So yeah, again, the studies do not corroborate in a specific cutoff level. So the question is, are viscoelastic tests helpful? Just to remind you, this is a whole blood assay. It informs us about the initiation of the clot, the strength of the blood clot, and whether or not there's lysis going on. Viscoelastic tests, they have proven their usefulness in a setting of cardiac surgery. This, I think, is very clear. It does not reduce mortality, but it does reduce the amount of red blood cells transfused, the amount of plasma, and the amount of platelets. And of course, this is during surgery, but they all arrive at your ICU, right? And just because they enter the door or they change the rooms does not mean that you should change your policy. So I would advocate the use of viscoelastic testing also in the post-operative phase of cardiac surgery on ICU. But this is a specific subset. What about other subsets? I guess we are mostly interested in infection and inflammation subsets. So this is a small study looking at the predictive ability of TAG in hematology, ICU patients with infection. And yeah, these results were not very promising, right? It was really flipping a coin. If your R time is around 1.5, it's really flipping a coin. It doesn't just say anything. So what we did is we tried to also answer this question in a population of ICU patients with a consumption coagulopathy, which means that you're admitted with ICU with the DIC risk factor, not necessarily meeting criteria of DIC, but having a risk factor, and these are the known risk factors over here. And also having already some coagulopathy going on, as indicated by a mild decrease in your platelet count, but not yet bleeding. Then we prospectively followed up these patients for bleeding defined by the WH criteria, fatal bleeding and major bleeding needing 2 units of red cells or any intervention to stop the bleeding, and minor bleeding is everything but major or fatal bleeding. So there we found, it's a small subset of patients, we found a high prevalence of bleeding of 45%. And we did find some differences between the cohort of not and bleeding or bleeding in terms of the clotting time, which was prolonged in the patients with bleeding. The strength of the clot was lower in the patients with the bleeding, and the lysis was less in the patients with bleeding. So there are some procoagulant changes, and there's some hypercoagulability changes, and this really fits within the pathophysiology of DIC, which is characterized by an absence of lysis, right? But if you then plot these in receiver operating curves, it's very poor. You cannot make a cutoff level here, so weak predictive ability for ICU. So yeah, I guess viscoelastic tests are not the answer at this moment. But can we look at other predictors? We have these great set of databases that are available. So can we ask the question there? We have the MIMIC database, but and some questions have been answered. For example, patients admitted for gastrointestinal bleeding, you can say, okay, what is the chance that this patient would need subsequent transfusion? But that really is another question and saying, okay, who will bleed? And that's because bleeding is not captured in these kind of databases. And it's not likely that they will be captured in the databases that are about to follow, because this would, it requires clinical judgment to do that. So we can rely on trial data that have investigated interventions and where bleeding has been captured prospectively. This is let's say, a fairly old trial, already 10 years old, but a large number of patients, bleeding was very well documented, and also a large set of predictors within that set. I know you can't read it, but what is of interest here is the APTT, the platelet count, and whether or not patients had surgery, and whether or not they're receiving anticoagulation. So I think, well, okay, this may be very useful to put into a model. We followed up on this. We are in an ongoing registry of patients, again, with a DIC risk factor, and we follow them up for bleeding. What are the risk factors for bleeding that we have? And I'm showing you preliminary data in 662 patients. And we found findings which are quite similar with the trial that I just showed you. Again, anticoagulants on admission, SOFA score, hemoglobin, low hemoglobin, that all makes sense, right? That this is a risk factor for bleeding. And we also found age, and in particular, low age was associated with bleeding. I don't have an explanation for that, it's just what we found. So this kind of odds ratios is always, I think, okay, how to deal with this in the clinical setting. But what you can do is make these kinds of tables, okay? And you can plot the risks and combine them with several scores. And this will give you, and these are percentages, so you can just read, if my patient has this and that, the risk of bleeding will be 82% or 42%. So I think this can be very informative for our clinical practice. And I guess the most important thing that I can tell you today is this, right? What is the relevance? You may say, okay, well, I know that they will bleed. What can I do about it? But this is very reactive. This is a passive way of thinking about it. A more active way of thinking about it would be that you modulate the level of anticoagulation. And just to remind you, the level of anticoagulation that is validated in ICU patients it's not validated, it's not set in stone. We do not know the optimal level of anticoagulation in those patients in need of anticoagulant therapy for whatever reason. We just do not know it. So whatever the APTT or the anti-10A levels that we target are mostly derived from these very old studies performed in patients that were on the ward, not on ICU, in which hemostasis is obviously very altered. So we don't know this. So I guess there's a lot to do and a lot to find out to improve the risk balance of anticoagulation and bleeding in ICU. So to conclude, bleeding in ICU is frequent. We may be able to, with fairly good prediction, be able in the future to say, okay, who will bleed and who will not. This will probably include factors related to disease severity, type of patients, and perhaps viscoelastic testing. And this will enable us to personalize the dose of anticoagulant medication. And I would like to thank my friend and co-investigator Marcella Muller from Amsterdam, as well as Romain Dujardin. He's a PhD candidate, and he did all the work. Thank you for your attention.
Thank you very much. There's still a way to go with anticoagulants. Questions from the audience?
So thanks for the presentation. In the preliminary data you're showing, platelet was not, I think, in it, or was it?
It was.
Oh, it was.
Yeah.
And the age, could it be hematology, like admission diagnosis? Was that in the analysis? So because it's indeed an observation, like why young people?
You would think otherwise, right? That older people receiving antiplatelet, anticoagulant medication, that they would be prone for bleeding or having a disturbed endothelium, etc. But so we have all these subsets of patients in the registry that they may differ. So you can imagine that hematology being a risk factor for this will be very different from sepsis. So we need to dive in and make these analysis, and we haven't done it yet. But good point. Thank you.
Can I ask you one question for this? So how many people were there with lower age? Because the risk ratio was 0.99. Could it just be an effect of, low numbers and
It could be,
stuff?
yeah. And in any way, the effect is small.
Yeah.
I agree. Yeah.
All right, if there are no further questions, thanks a lot. We move on to the last talk. That's gonna combine it all, explain it all, and solve the remaining questions in the 15 minutes to go. Marc Maegele, how to put it all together.
Thank you for being here. And this has been really a challenge, how to put all these brilliant information together. And I really would like to congratulate the presenters, Pierre Bouzard and Alexander Vla, for sharing their results from their prospective randomized control trials with regard to the use of platelets and regard to the use of PCC. So when I received the invitation to this talk, how to pull it all together, I said, what are you going to say? So, and then I looked up the program and I said, well, I think the best way would be some form to incorporate, to integrate all this different information into one talk, and to set out something like a perspective for the future, where our journey can go with bleeding trauma patients. Just to set the stage, and this has been published in the New England Journal of Medicine 2018, basically summarizing the impact hemorrhage-related injuries and entities basically have with regard to outcome in these patients. And this is data from the US, and to put it more or less on a global scale, this is related death per year and years lost of life as a new criterion to assess the impact of a specific entity. And as you can see here, there are major reasons why basically patient can bleed, and one is trauma. Then we have the gastrointestinal diseases, you have obstetrics, and you have the vascular diseases and injuries. And of course, bleeding sites or bleeding can occur at any site of the body, as you can see here on this right lower hand cartoon. Bleeding can relate to trauma, to a bone fracture, and then you have this lethal triad going on that's being composed out of hypothermia and existing coagulopathy, and this then leads to acidosis and this spiral that's really hard to overcome when it comes to treatment in these patients. Obviously, bleeding and blood loss triggers a whole series of further events within the body, and causes coagulopathy that's then in part being related to a depletion or loss of coagulation factors due to the blood loss, a depletion of coagulation factors. Then you have several pathways involved that basically trigger the further sequelae of the coagulopathy of bleeding, starting at the activation, for example, of the protein the C pathway. And then obviously you have specific mechanism activated with regard to local and systemic hemostasis. What we also know is that if people die from hemorrhage, they usually die very fast. And this is an example from the trauma setting. So if people come with a very severe bleeding into your emergency room, so you need to act really quickly. Because hemorrhage leads to death at a median time of around 1.6 hours. This has been shown in this retrospective analysis published back in the Journal of Trauma in 2017. And most of the cases actually occurred during the first 4 hours. And on the right-hand side, you see a sub-study from the PROPA trial, a trauma trial from the US prospective randomized control trial, But basically, the authors have shown the impact of early hemorrhage control with regard to the outcome in these patients, and they concluded from that sub-study, including more than 400 patients, that with every 15-minute decrease in time to hemostasis, this was clearly associated with decreased 30-day mortality and also a secondary complication associated with bleeding and therapy. So the overall aim, the clinical aim or clinical strategies should be directed towards stopping the bleeding as quickly as possible, prevent further blood loss, prevent the patient from exsanguinating, and to restore hemostasis as quickly as possible. Just a very brief overview of our surgical strategies we have available. These follow usually the classical damage control surgery and damage control resuscitation protocol. So if you really have a bleeding source, you put pressure on the bleeding source, you stop the bleeding, use tourniquets, and there has been a vast database available now from the literature, from the military setting. The use of tourniquets been advocated, and there's been a major component of pre-hospital hemorrhage control in emergency situations. Use the pelvic binder to close the pelvis. Then in hospital, we clearly follow the damage control surgery strategies, and then we have these advanced technologies and techniques available, looking at endovascular control, REBOA, and selective angioembolization. Restore hemostasis. So what is basically needed? What are our ingredients to promote coagulation within our body system? We heard nicely from Alexander Vla that platelets obviously play a major role, and from his PACER study we know, and we've just seen that a decrease in platelet numbers obviously is associated with an increased risk for bleeding, so platelet transfusion might be an option here. But we also heard from his talk that the administration of platelets might also cause harm, and we still don't know whether the platelets we actively transfuse to the patient really do what they're supposed to do. What we also heard from Pierre Bouzard was the use of coagulation factors, the use of PCC, although his study was gave kind of a disappointing result, because we are expecting when we give the patient PCC that coagulation might function better. Calcium obviously is a very important cofactor and is always depleted in severe bleedings, especially when it comes to massive transfusion situations. And obviously the environment needs to be optimized where optimum coagulation can take place. So we all know from these very basic studies and from our medical textbook that obviously the temperature and the pH level have a tremendous effect on the activity of coagulation factors. So the environment needs to be corrected so the optimum coagulation can take place. Coming back to the platelets, as outlined here in the middle of the slide, we need a certain number of platelets, obviously, to promote adequate coagulation, because the coagulation process takes place in the presence of calcium on the surface of activated platelets. And whatever model of coagulation process you basically take, might be the classical Y-shaped model of the distinguish between the extrinsic and the intrinsic system, or this novel cell-based model. The final step is always the conversion of fibrinogen through activated factor A thrombin. We also heard about the thrombin generation previously today. Is the conversion of fibrinogen to fibrin, and then later cross-linked by activated factor 13 to promote optimal clotting. We all know from different studies that in the context of acute blood loss and bleeding, basically all coagulation factors go down. They might be depleted, they might be infunctional, they might be lost through the ongoing loss of blood out of the body. And this also translates into our laboratory parameters. We also heard from Beverly Hunt today the advantages and disadvantages, especially when we talk about novel anticoagulants. The classical parameters of coagulation seem to reflect factor activity quite well. We also heard from the different speakers today about the different approaches, how we clinically manage severe blood loss and bleeding. So there are basically different approaches. One approach might be that the patient basically gets all at once. Then we have the ratio-driven approaches that's promoted primarily from the colleagues in the US and the UK. Then we heard from Nicole about the more or less targeted approach using viscoelastic testing devices. This is what the European trauma guideline, Pierre Bouzard already alluded to you to that guideline suggests at the moment, at least for the trauma setting, but I think the ESA guideline runs rather in parallel to these recommendations, that at least in Central Europe, we are more eager to follow a goal-directed therapy approach that might be based on standard laboratory coagulation values or viscoelastic testing, especially when you look at the component therapy, where you basically administer or supplement those factors that are being depleted or lost by the patient due to blood loss. We promote the use of fibrinogen, as earlier outlined by talking about the coagulation system. Fibrinogen is a very important factor, and that reaches critical levels first in the context of acute bleeding. So, and this can be clearly also outlined and diagnosed severe fibrinogen depletion or hyperfibrinogenemia. Or a lack in fibrin polymerization by the use of viscoelastic testing assays. And the European trauma guideline really recommends specific values as related to a specific we take ROTEM or ROTEM viscoelastic testing traces on when to apply specific targeted treatment approaches. The use of coagulation factor concentrates, as outlined by Pierre Bouzard, we still, and he also alluded to you to the updated trauma guideline that has recently been published earlier this year, still recommends that PCC may be administered based on viscoelastic evidence of delayed coagulation initiation, although knowing that the results from your trial are challenged, and this was also a key message from your talk on the results from the ProCoag trial. This might be considered maybe in the future whether we need to have a more specific indication for the use of PCC instead of using viscoelastic testing assays. With regard to platelets, of course, Alexander Flahr already alluded to you nicely this correlation and the ongoing discrepancy with regard to recommended platelet trigger values on when to initiate a platelet resuscitation. This is what the European trauma guideline actually recommends, but in line with other guidelines. So especially in patients with TBI or ongoing bleeding, the platelets, as outlined, coagulation process takes place, occurs on the surface of activated platelets. We need to have, especially in the context of acute bleeding scenarios, we need to have a certain amount of platelets for the blood to coagulate. Obviously, you can also use the viscoelastic testing assays to more precisely guide your platelet transfusion efforts in considering the amplitude difference in the FIBTEM and the XTEM subtests. There have been several algorithms suggested for different indications with regard to the use of early goal-directed therapeutic approaches using viscoelastic testing as outlined here. for PPH, for cardiovascular, for trauma, and for liver, but they usually follow a stepwise approach and concept, and suggests specific trigger values on when to initiate in the stepwise approach specific coagulation factor supplementation, but also including platelet transfusion and the use of FFP. Beverly Hunt, in her talk, briefly outlined to you the use or the increasing use of anticoagulation drugs, especially in the elderly population, as we are facing demographic change throughout the Western world. We see more and more people being diagnosed with cardiovascular diseases being put on DOACs. DOACs, meanwhile, as outlined already by Beverly Hunt, have now surpassed the use of VTAs in the prophylaxis of thromboembolic events in this patient population. But the real problem in these patients is, especially when those patients fall down and get injured, especially on the head, and the most common cause of TBI commonly is not the young risk taker anymore, it's the elderly with a low fall in the local environment. The situation, the clinical situation is especially complicated when those patients are under DOACs, as outlined here. This is a single center experience where 1 in 4 patients on DOAC above the age of 16 with TBA experienced a substantial hemorrhagic progression on follow-up CT with subsequent impairments in outcome. And especially this is a subset of our Center TBI project we recently concluded in Europe, where we basically have shown that DOAC specifically put patients at risk for hemorrhagic progression to a larger extent, to a larger percentage as compared to other antiplatelet and anticoagulative agents. And this is a clinical example of a patient when we didn't have access to a specific antidote. This was a 70-year-old patient with a severe traumatic brain injury on the bigatron. So this shows a dramatic increase and deterioration of his intracranial hemorrhage 2 hours after admission in the controlled CT scan. And then we had to take the patient immediately to the OR for emergency hemicraniectomy and to remove the intracranial hematoma. This is what we, and you probably also see quite frequently now in your emergency departments on the upper right-hand side. This is a pre-tibial hematoma secondary to a very minor trauma in a female patient under apixaban. So this is basically not life-threatening, but it causes enormous clinical complications because you need to evacuate the hematoma. You have this hematoma. You have this large soft tissue defect. You need to cover in the later sequence of treatment in collaboration with the plastic surgeons. So not life-threatening, but causing especially severe problems in the later clinical management. More dramatic cases, this is a 60-year-old female, low fall under the bigatron, clinical presentation with the massive subcutaneous emphysema, but you can see here from the CT scan a massive hemopneumothorax with acute delivery of about 1 liter of blood when we put the chest drain in. And this patient was then antagonized with iradicimab and TXA, received some blood products, and under maximum intensive care, she survived on the ICU. But there are also fatal outcomes in these patients under these DOACs, and as outlined also when Beverly showed to you the PK data in these patients. These drugs usually have I would say, a predictive pharmacokinetics, where you basically every single hour from the time point of a drug intake basically puts you more or less on the safe side. And also the colleagues here in Denmark, when this patient was admitted with a subtentoric femoral fracture, surgery was initiated. So these colleagues basically waited for 15 hours, and then they did the operation, anticipating not a substantial anticoagulation effect anymore due to the drug. They cut into the patient, and the patient started immediately bleeding, lost more than 6 liters of blood, and died due to secondary to multi-organ failure the next morning. So we are very lucky that now we have access to specific antidotes for 10A inhibitors, and that's the adexanet alpha that was nicely alluded to you by Beverly Hunt previously in the session. And for the dabigatran, for the thrombin inhibitor dabigatran, we have ISICEM available. And you can see here, they usually act very fast. The antidotes work very fast, but in 2 to 5 minutes, you have a clear and almost complete reversal of the anticoagulative activity exerted by these 2 drugs. And the last talk we heard was a brilliant talk by Michael Reid from Australia, looking a little bit into the future about and highlighting the controversies again around the use of whole blood, both in the military, in the pre-hospital, and in the in-hospital setting. Is it back to the future? Because this technique of autotransfusion, whole blood transfusion, is essentially not very new. But it's integrating because it has all components in one single unit. It can be stored it can be used for 3 weeks, but experience so far is limited from the military and less developed world, and has shown some, as outlined by Michael. The literature is still a little bit controversial. It has obviously advantages, especially when in the pre-hospital phase of care, when pre-hospital times might be a little bit longer than as compared to Central Europe. However, what you need to consider is when you set up something like a whole blood program, logistics have to be taken into account, costs have to be taken account. And especially how this will be used. And I think Michael already also gave a very, very important topic to consider is the potential lack of donors, and if you really set up such a program on a larger scale. It is currently highly advocated, as already outlined in Michael Reid's talk, by the American military, and this is a consensus statement by the Joint Trauma System and the Defensive Committee, where basically there is this statement that whole blood should be used to treat hemorrhagic shock. Whole blood should be available within 30 minutes. Michael already also alluded to you the time constraint in this one study, where the survival benefit might only be related to those patients who survived actually long enough to receive the product. The Joint Trauma System consensus statement also includes that all pre-hospital medical providers should be trained in using these techniques, and assuring the adequate circumstance and environment to assure the environment that this strategy can be put in place by deploying military, should undergo a pre-screen, of course, to serve as potential donors in this context. And with that, I hopefully wrapped up the session a little bit. Again, highlighting the major topics of the sessions, and I'd be happy to answer any questions. Thank you so much.
All right, time is up for this session. I want to close it. Thank you very much for this wrap-up.